Yeah, I think we should. It says live on
Okay.
YouTube as well. I can see up the top.
Yep, I've just clicked that. So I'm going to broadcast now.
Okay,
And
great.
we are live.
Okay, so numbers are steadily joining us here, Anna. So if you can see at the bottom, the participants, we've got 659 climbing. All right, well, the numbers are just slowing down a bit there, so I think that we should make a start. So welcome everyone to the Critical Care Education Services Medcast and Fisher and Paykel webinar series. Now, this is the first of 3 webinars that we've got. The other 2 are coming up on the 21st of July and the 27th of August, and I'll give you those dates a little bit more towards at the end of this webinar. So we've got a huge number of people that have subscribed to the webinar. And if we get to the point where our room, which can take 1,000 people, is full, then you'll be directed to a live streaming on YouTube at this point. Now, I'd like to, my name's Ken Hambridge. I'm the Principal Consultant and Founder for Critical Care Education Services. And I'd like to introduce Anna Andreas, who is the National Education Manager with Fisher and Paykel Australia. Anna started her career in New Zealand in 2000 with Fisher and Paykel, and since 2004 has been the education manager of the team here in Australia. And she has extensive experience in education and clinical application of the physiology of the airway for adult, pediatric and neonatal respiratory support, and an in-depth knowledge of the physiological mechanisms and applications now well researched. Now, Anna has a first-class honours degree in physiology from Otago University, which is in Dunedin, New Zealand. And when I saw that, I said, okay, that was interesting to the Dunedin. I've been there to do some work for the Department of Critical Care Medicine at the hospital there and the university some years ago. Now, just a few housekeeping things before we get started on the part. We've got a chat room, which if you want to talk to other people or if you have any technical issues, tonight we have tech team support from Greg and Abby from the Medcast group. And if there's something that you can't resolve, then put it into the chat room. We have another box, which is the Q&A box. And the Q&A box would be good for you to pose questions that you would like Anna or I to ask during the actual presentation. Now, we did have a pre-webinar survey that there's a Survey Monkey that you could scan the QR code on the front if you hadn't done that. And there's also a post-webinar survey that I'll have up at the end of the actual webinar as well. Now, in the Q&A box, you can see that of the principles we're going to look at is COVID-19 and its use. And we did have quite a few questions relating to that. So perhaps hold off on any of those COVID-19 questions until we get to the end of the webinar when we talked about the COVID-19 recommendations at this point. And also, because of the large number of people that we already have 814 people currently looking at the webinar. We may not be able to answer every sort of question that's coming up. So I'll be looking for groups of questions that we can then talk about and discuss as we go through. So I'd like to hand over now to Anna to present the part, and I'll be here in the background looking at the Q&A box and having some other input at various stages. So over to you, Anna.
Thanks, Ken. Look, it's interesting when we look at this topic or this application, there's just so much we could talk about, and we have probably less than an hour to do so. So what I plan to do is take you through a very brief introduction of what it is, and this really is explaining to you what we're capable of achieving with the therapy. And I do want to make sure you understand the mechanisms behind the use of high flow. There's a couple of really unique mechanisms at play here that I want to explain and spend a little bit of time looking at the physiology of that. And with regard to the evidence, look, we're probably not going to get so much time to look at the clinical evidence, but I will review that. And it really does take you through the fact that this therapy has been out there probably for about 12 to 15 years. And the very first case study introducing us to the concept of high flow was in 2007. So we've learned an awful lot from the research, and we have a pretty good idea of how it works. And we also have quite a good understanding of the patient groups where we're getting some real benefits. And as Ken mentioned, we are certainly going to address the COVID-19 discussion. And I think what I'd like to do there is have a look at the recommendations for nasal high flow with the ANZAC's guidelines, as that changes daily, and we'll look at what seems to be the most current, and then look at some interesting research that has just come out looking at the use of nasal high flow in Hong Kong and the States, as they have unfortunately had an awful lot to do with COVID, unlike Australia. And quickly have a look at the setup, and then, as Ken said, let's hope we can get some time for some Q&A. So if we just move to the next slide. This really does overview the therapy itself. So what can we achieve with the Airvo system? We humidify the flow for the Airvo, and because of that, we're able to give decent flows with the Airvo. And these flows are primarily air. So the Airvo, of course, delivers its own flow. We have air running through the system, up to 60 litres for adults. We can be very precise with the oxygen you are able to deliver. It's not an oxygen delivery device. You have the ability to titrate oxygen in, so you find that you tend to use less oxygen, and you can be quite precise with the FiO2 that you are delivering. And of course, the Airvo tells you exactly how much oxygen is running through the system. The nasal cannula tend to be the cannula or the interface of choice. We do certainly have a mask option, but very rarely do we see that used. A mask kind of removes all the beneficial effects you get with the cannula, so it's kind of counterintuitive to use a mask option. And we also have the tracheostomy connection, which is ideal if you have a direct trachea connection. You're able to supply nice warm moist gas into the part of the airway that really does require it the most. So we often see that utilised in many trachea patients with a trachea tube in place. So that's kind of an overview of the system. I'm thinking a lot of you perhaps are quite familiar with the unit itself. You've used it, and you're perhaps seeing it more and more. And we do see that as people become more confident in the use of it, use a higher flow, and more Airvos are turning up outside of the ICU in the surgical medical wards, etc. So if we then go on to the overview of the mechanisms. Now, there's quite a few here. I want to spend some time on the mechanisms reflecting respiratory support. We have some very interesting physiology at play here. One of the reduction of dead space, which we certainly will cover off on, and the other is this whole generation of pressure, which is been debated over the years. It has been debated over the years exactly what the pressures are, and I think it's very, very difficult to quantify that, but we'll have a look at how it's generated, and I think that makes a lot more sense. Airway hydration is something we've kind of grown up with. Look, you can't deliver this therapy without humidifying it, and of course, let's not forget the reason why we are humidifying high flows. We need to look after the airway itself, as well as the ability to give the high flows. So looking a little bit more closely at airway hydration, if we break it up into two subtopics, as I think it's really important to understand science behind it. And if you do, it really helps with understanding what you are achieving in the first place with the application, and I think also troubleshooting. And if you have a good understanding of humidity, it certainly helps understanding what our systems do. It's not complicated, it's not a complex unit, but there is a lot going on in the background of the unit, and I guess that's the beauty of the technology. Now, I think at this stage, we're going to throw a poll out there, Ken, and just see what you guys understand with regard to water vapor. So what are your thoughts on this? Water vapor is capable of transporting pathogens such as viruses and bacteria. Now, would you believe that to be true, false, or are we unsure on that one? I think we give it a bit of time, do we, Ken, until...
Yes, so Greg will just monitor based on the number of participants and percentage of responses, and then he'll say when he's going to close the poll.
Cool. All right. So some of you who've perhaps attended some of our education sessions before will be all over it, and others may perhaps need a bit of a nudge to remind ourselves of this one.
So the poll results are in, and overwhelmingly 79% of you said true. So back to you, Anna.
Ah, very interesting. Is that your final answer, I must ask? So if you have a look at the slide that's just come up on the screen, and you look at the size of water vapor, the first thing that comes to mind is you think, gosh, it's really tiny, and it is. Water vapor is 0.0001 microns in size. And to put that into perspective, the width of a piece of paper, a single A4 piece of paper, is about 75 microns. So water vapor is invisible to the naked eye. You don't see it, it's present everywhere, air conditioning kind of controls it, but it's individual water vapor molecules. And to achieve water vapor, you need to heat water a lot. You need to heat it more than ice to liquid. You need to heat it more than liquid to steam. You need to add that extra bit of heat to get individual water vapor molecules. And that is what we create in our chamber. We create water vapor. And it's not that difficult as long as you have an extensive degree of heating of the water and you have gas flowing through the chamber. You will create water vapor. We've taken advantage of a very simple law of chemistry, which we are going to actually test you on in the next slide, so I won't tell you what it is. But once you do that, you can control the level of humidity in your gas. Now, if we have a look at the size of the water vapor in comparison to your pathogens, your viruses and your bacteria, there's a vast difference. And this is important. It kind of tells you one thing. Water vapor is literally incapable of transferring pathogens from A to B. And that is the science. That is something you can't really argue the point because it's just too small. And when you look at the size of a nebulized water droplet, and that of course is a cluster of water molecules all clustered together, you can see the size differentiation tells us that droplets are very, very capable of transferring pathogens. Pathogens are very opportunistic. They need a means of transfer. They will certainly jump on an aerosol. They'll certainly jump on a nebulized water droplet. And that's how we transfer contaminants from A to B. Now, the other really important concept of this slide is where does coronavirus fit into this whole equation? And if we just hit the slide again, it'll kind of show you where it sits. There'll be a little pop-up. And if you have a look at coronavirus, it's probably one of the most atypical sized viruses. It's 0.1 microns. It's literally right smack bang in the middle of the virus. Yes, it's got those little spiky projections, which are kind of characteristic of a virus, but you can see it's a virus size, and that is because it's defined as a virus. Now, the important concept here is that water as vapor cannot transfer the viruses down the tubing. So water vapor will not transfer a coronavirus from your chamber down the circuitry. And that's something you need to keep in the back of your mind. There's lots of other things going on, which we're certainly going to cover. But I think when you look at the science of your pathogens versus your water vapor, it kind of makes sense. So you can also see how easy it is for a droplet to transfer coronavirus. And that's exactly how it is transferred from person to person from bench to table, etc. So that is a really important concept. And the next slide, I think, is another poll, and this will help us understand the second really important concept with humidity.
So this one says, as the temperature of the fluid decreases, the water vapor pressure increases. So
Sorry, I should
true,
remember that.
false, or unsure. Okay, so 50% said false, but some of you were not convinced by it as saying true, and some were unsure. Well, the actual correct answer is false, so I'll hand back to Anna to discuss that further.
Well done. We've got a bit of a tricky one, but yes, there's a really tight relationship between humidity and temperature. And this is just one of those very simple laws of chemistry that we learn in probably, I don't know, Chemistry 101, that as the temperature of a gas goes up, the ability of that gas to hold water vapor increases to its maximum capacity. So if you control temperature, you will by default control the amount of humidity in a gas. That is presuming you have sensors to control temperature and you have water available. That's pretty much all you need to create humidity. So it's not difficult to create a saturated gas. And that's kind of what we're doing with the Airvo. That's what the chamber is achieving. We have water, we have temperature sensors that control the temperature of the gas quite precisely. And we just take advantage of this little graph that you see in front of you. So of course, the aim with regard to what we deliver is 37 degrees. That is body temperature, that is physiological, and we know the science books tells us that at 37 degrees, when it's completely full of water vapor, you have 44 milligrams per litre of water vapor, and that's physiological. That's kind of what the lung expects. So you can also see as the temperature of a gas decreases, its ability to hold water vapor decreases. And you think to yourself, okay, at 37, I can hold 44. At 31, I can hold 32. So where has that 12 milligrams per litre of water vapor gone? You can't hold it anymore. The gas cannot keep it in vapor form. And what happens is that's where your condensate comes into play. So to kind of put it into perspective, if we jump to the next slide, and this is kind of a progressive set of I think it's 3 or 4 slides. So this gives you a conceptual idea of how temperature and humidity work together and how we design our systems. We control temperature very, very closely. And it's very easy to do that. You just need temperature sensors in your units, and we've got them in the chamber and in the circuit at the end of the airway. So we control and monitor the temperature constantly. And we know in the presence of water, we can manipulate how much humidity is in that gas. So we've got a square there, it's at 25 degrees and it's completely full of water vapor. It has 23 milligrams per litre of water vapor in it. Now, if I wanted to get more water vapor in that gas, I can't just add more to it, I have to heat it. So I add heat. And now I have a square little rectangle that's 37 degrees. But I haven't given it any more water yet. I've given it space for water vapor, but I'm not adding water yet. So you see the level of humidity in it is the same, 23 milligrams, but I've got room for more. So the percentage has dropped. To allow for that, I then add water. So I then click on the third section and I add water into the container. Now I have what I want. I've met my mark, I have water, I have heat, I'm controlling it to 37. Now, if for some reason you delivered a gas along a circuit and you didn't heat that circuit and the gas cooled quite extensively, the result is the gas cools down to probably what would be close to room temperature, which is the next little section. And of course, the humidity is going to be lost as condensate. So that will be the last square that's going to come up any minute. There we go. So once we've cooled the gas down again, the gas can no longer accommodate for that humidity and condensate as the result. So condensate, in theory, is humidity the patient will not get. And if I was to say one challenge with our systems that we have worked very hard to overcome with regard to engineering, and that would be managing condensate in our systems and our circuitries. It's all about insulation, it's all about preventing heat loss, and of course it's all about heating the gas as the gas travels from the chamber to the patient, and this is the reason why. So that kind of gives you the science of it. That is what humidity is, and it helps, I think, in the understanding of what the system does, the importance of maintaining temperature, and the importance of having heated circuitry everywhere. Minimal unheated space is what we recommend when we put our systems together. Okay, so let's take a look at the why, the whole point. What's the whole point of conditioning gas? The physiological reason why we condition gas. And this probably is best explained when you look at the functions of the respiratory system. And if we sort of introduce those with regard to the main function, and that would be ventilation or gas exchange. And to ventilate, you need to have an open airway. So you need to make sure your airway is always patent. So you need to be sure anything that gets in is cleared and removed, or you get it out somehow. So that's secretion clearance. So the airway remains open. Any extra mucus, and we see this on occasion with very unwell exacerbations, you want to clear that mucus. So we have to have an efficient secretion clearance system. We have to have a good ventilation system. We also know the ventilation, the respiratory systems involved in voice control, it's olfaction, it's sensory, it's smell, and of course we have very coarse hairs in the nose, get rid of all the big particles. So defense is a biggie alongside ventilation. And when you look at the defense systems we have to clear the airway, it reflects how important it is to keep the airway open. So to have a gas that will work well in the airway and keep everything physiological, we need to condition it. And normally we don't have a drama. In fact, the structure that does most of the work occurs very quickly, and that's our nose, our nasopharynx, which brings us to the next slide. So as we inspire gas, we inspire it at quite a rapid rate of flow, and we do that for a reason. We have a very fast flow rate going up into our ears, and we take advantage of the fact that the nose adds most of the heat and moisture we need for good gas conditioning. If we go to the next slide, that'll reflect that. So we have a nasopharynx that is designed pretty much for gas conditioning. That's its primary function. It is made up of very small little tubules and openings, and inspired gas travels through the nose, picks up all the heat and moisture from the mucosa, and by the time it reaches the back of the airway, it's very, very close to 37 degrees. So the nose does an amazing job, and it's one of the primary reasons why we breathe nasally. Infants do, we do while we're at rest, and we do this to take advantage of the nasopharynx and the gas conditioning. Of course, when we are in duress and we're exercising, or perhaps we're working very hard, we will breathe orally, but that will give us a small deficit with regard to gas conditioning. So normally we don't have a problem, and we condition the gas extensively, and this is to keep the airway clear, secretions moving, and physiological. So if we then have a look at the defense systems we have, this kind of reflects the importance of a clear airway, which brings us to the upper airway defenses on the next slide. These are the defenses we're referring to that are mechanical. We've got a number of mechanical reflexes: a cough reflex, the gag reflex, a sneeze reflex, all very, very effective in clearing contaminants that make their way into the airway. And they are very well established in adults, not so much in infants, but in adults we rely very heavily on these reflexes, and they cause a huge rate of airflow, and that's how effective they are in removing the obstruction. Should something not be cleared by perhaps an upper mechanical or down through the airway, we have our lower defense system, which is even more extensive. And that brings us to the next slide, which is the mucociliary transport system. This system is our primary defense. And I say that because it is the most established defense system pretty much from birth through to the life of your respiratory system, so to speak. So it's present from your nose down into your 15th or 16th generation bronchi. It is made up of mucus lining the airway, cilia that are madly beating that mucus, and that mucus is always moving upward against inspired flow coming in, and that is how we clear secretions. You see when someone becomes unwell, the very first indication they're having some kind of a problem is possibly hypersecretion. What's happening there is the mucociliary transport system is reacting to an infection, a disease, a contamination, a foreign body, and hypersecreting mucus. In response to that, it just rips the secretions up the airway and we get rid of any of those contaminants. So it's a very well-defined system. It's very efficient. You don't really realize it's going on. It's in the background. It's not an undue duress, but it does struggle when you dehydrate the mucosa. And the next slide should bring up a video of the one after this one. And this kind of displays two things. The first section on the left-hand side is, sorry about that, is a nice healthy piece of tracheal airway tissue. So that shows you how easy it is to preserve a healthy piece of tissue, even though what they've done is they've taken that piece of tissue out of a trachea and bathed it in a physiological solution. So it's very, very delicate. They've kept that alive and functioning. And the video on the right-hand side shows you that piece of tissue when they dehydrate it just a little bit. So just 10% reduction in moisture. And it's very, very surprising the damage you see. So I'll let the video run and the nice man should walk you through it.
Video microscopy, mucus clearance on live sheep trachea under a variety of temperature and humidity conditions. The impact of reduced temperature and humidity on mucociliary transport is shown very clearly in this experiment, which compares the behavior of two tracheal samples. The first, on the left, is at normal humidity. The second at slightly reduced humidity, 90%, only 10% below normal. Size is indicated by this scale. You will see that when the relative humidity of air flowing over the trachea is below 100% for a long period, the mucus layer will dry out. Of course, this prevents proper mucociliary transport, leaving potentially infectious debris stuck in the airway. For both recordings, the air was supplied at 25 liters per minute and 38 degrees Celsius from the humidifier. For simplicity, unidirectional airflow has been used in all the demonstrations. As we mentioned earlier, heat and water vapor are normally partially recovered during expiration. As the clip starts, the right trachea has been exposed to a constant airflow at lower humidity for 15 minutes. Although you can see tiny beating cilia flickering in the background of both clips at this stage, debris in the mucus of the right clip are stationary. Mucus transport is essentially stopped. The dark spots, moving quickly across the left clip now, show debris being cleared by effective mucociliary transport. After only an hour at the lower humidity, the mucus layer at the right has completely dried out. The clip is quite short, so let's play it again. Remember, the right trachea has been exposed to 90% humidity for only 15 minutes. Then, after an hour, it has dried out completely. Any debris will remain stuck on the trachea and may lead to infection.
So what I think is very surprising about this video is that it's a very delicate piece of tissue, but they've managed to maintain it on the left-hand side, and that is just looking after normal physiological conditions. And the other side of this is that it didn't take long to see complete dysfunction of the defense system after a very small amount of moisture has been taken away. So it does certainly reflect our mucociliary transport system is very, very reliant on physiological conditions. And this is where the gas conditioning comes in. This is kind of the mainstay, regardless of the flows, regardless of the therapy. This is pretty much why we humidify the gas flows. Now, the second mechanism I want to talk about is something a lot more unique and something that is a real physiological benefit. And we've only just been able to study it because we've been able to give high flows into people's airways. So if we move on to the next section, I think there is the third poll. Be interesting to see your thoughts on this poll before we actually talk about this topic. So let's see how we go. So nasal high flow therapy modifies dead space by, your thoughts are that it increases the dead space volume, decreases dead space volume, or there is no change in dead space volume.
So we'll be putting the results up shortly.
Okay.
And here we are. We've got 75% say decrease dead space volume. And yes, that is the correct answer. So back to Anna to explain why.
Excellent, excellent. And this is just one of those really unique physiological benefits that has only really just recently been very well researched. So we have a really good understanding of this now. And when you look at the research, all the research, when they look at the advantages of high flow, will reference this particular benefit. So I think the first thing to perhaps review is what dead space is. And I don't want to spend too much time on this. We haven't got so much time tonight. But if I was to say to you, dead space is that part of your respiratory system that does not take part in gas exchange, I'm thinking you'd possibly agree. And you're not all going to put your hand up, so I'll just keep moving on with that one. So in terms of physiology, dead space is pretty much, if you click on the next slide, that section of the airway that you see in front of you. And that is a nice, normal, healthy airway. The parts of the airway that are involved in gas exchange are functioning. The parts that are involved in conducting flow into the lung are your dead space. You need to fill that up with air before you can ventilate. So whenever you look at a tidal volume, you must allow for dead space volume. And you need to take it away from the tidal volume because you can't use dead space volume. It really is just a space filler. And when you're unwell, what tends to happen is your dead space increases. And that is simply because you've got alveoli that are no longer functioning. They may be collapsed, fibrosed, diseased. They become dead space. So your dead space will go up. So if your dead space goes up, what happens to your tidal volume? You have less available for alveolar ventilation. So it starts to compromise. And this is why these patients struggle, certainly even at rest. So what we've found, and this brings us to the mechanisms, which is the next slide, we've found that when you drive a high flow of air into an upper airway, you actually flush out some of that dead space volume. You replace the makeup of the flow, the air that is in that dead space, with fresh gas. And as a result of that, fresh gas is available to the lungs sooner, and that improves alveolar ventilation. And this is something that has been quite well researched. There's some really interesting studies on it. They've done it on healthy volunteers. They've done it on simulated models. So we've got a really good idea of how it works. And if we go to the next slide, you'll also see the consequence of flushing out dead space volume, because of course dead space has some CO2 in it. There's about 5% CO2, and that's very acceptable. That's very physiological. When you drive a flow of air into your airway, you see on the slide here, on the right-hand side, the color change is a representation of a decrease of CO2. So that is showing us in itself that you've changed the makeup of what is in your dead space. It's one of those concepts you don't really want to overthink. We're not changing the dead space in any way, we're changing what's in it. And a good visual to represent that, see if I can actually bring this up. I'll see if I can share my screen to show you. Okay. Just helps us understand a little bit more. I'm hoping you guys can see an image of a man on the screen. I'm taking away his lungs. so that you can visualize his dead space. And if you have a look at the square, that is a conceptual square of tidal volume. This clear part is alveolar volume, the black part is dead space, and let's presume a tidal volume of 500 mils. So we're going to breathe at about 12 breaths a minute. And as you can see, the dead space sits there. It's the first gas the alveoli sees, and it's the last gas left in the conducting part of the airway before the gas is expired. And it's about 30% of your tidal volume. So that is absolutely normal. This person doesn't need any support whatsoever. But let's actually make him rather unwell. Give him a little
So
bit
Anna,
of lung
the
disease.
slide images are very pixelated here, so people are having trouble seeing the.
Okay, if it's not going to work, we'll move on. See if that's going to come through. Is it still?
Yeah, it's still very pixelated. So maybe if you just stop sharing and go back to Greg for.
Yeah. I think he has, hasn't he? Oh, here we go. Okay. Right. All right. Good try. Anyway, so in terms of what the dead space advantage is, ultimately you are improving alveolar ventilation for these patients. The next mechanism is this pressure idea. Now, I think that's going to come up. The biggest discussion points we've had when we first discussed high flow was its equivalence to CPAP. I'm just saying, can you guys see this, the presentation there, or?
Yes, we can see the presentation.
Yep. So one of the biggest discussions that we've had over the years is high flow and its relationship to CPAP, and research is telling us that we're seeing very similar advantages and outcomes on patients who would otherwise do very, very well on CPAP and BiPAP. And we were sort of scratching our head thinking this can't be right because it's not a CPAP system. And if I was to separate the two applications, CPAP is a continuous positive airway pressure. You control pressure and flow changes to control that pressure. So it's a pressure controlled device. When you compare that to high flow is a flow controlled device. You control flow, and yes, there's some inadvertent pressure as a result of that. So these two systems or the applications are at opposite ends of the spectrum, but we're seeing very similar results. And just recently, some great work was done that's showing us what's going on. So if we bring us to the next slide, just to break it up a wee bit, and click one more time and it'll take you to one side of a graph. So I just want to show you the difference between CPAP and what we call dynamic positive airway pressure as the pressure is consistently changing. On the left-hand side of this graph, you see a reflection of inspiration. And if you have a look at the yellow line first, that is pressure I would measure, and you guys, if I put a pressure sensor in the back of your airway and I got you to breathe in, if I then put you on a CPAP of 5, I would then see the red line. So as you breathe in, you're getting a consistent positive airway pressure of 5. If I then put you on a nasal high flow of 2 different sizes of cannulas, blue or black, you'd get pressures similar to what you see at the baseline there. So nothing really much in it. And that is true. In inspiration, high flow assists, it decreases work of breathing, but there's no additional pressure present. And if you click again and you show on expiration, this is where the advantage is. On expiration with CPAP, same deal. You're still getting your consistent, continuous positive airway pressure. That's why it's called CPAP. With the yellow line, there's not much in it. Expiration is really a passive process, as we know. With high flow, this is where the pressure occurs. So it's expiratory pressure, it's consistently changing, and it changes as your expiratory flow rate changes. It's very, very hard to measure as a result of that. Yes, there's pressure, there's certainly some kind of support, it makes a difference, but it is a very, very different way to administer pressure than your CPAP or your BiPAP systems. So I think for the sake of time, we'll keep moving, but please do remember that this is not a pressure-driven device, it's a flow-driven device. and pressure is pretty much a consequence of the flow rate. And if we go to the next slide, and if you wanted to have a correlation, I'm very reluctant to give a correlation. I don't think that you need to, but some people like numbers. So pretty much as you increase your flow, you increase your pressure, and it's very loosely about 1 centimetre of water pressure per 10 litres increase in flow. And to visualise this, there was a really good study done in Queensland some years ago. This is the Corley study, which is on the next slide. These guys managed to get their hands on this electrical impedance tomography system, which is fantastic. It gives you a real-time imagery of lung inflation and ventilation. And they decided to look at high flow versus standard oxygen therapy on extubation in post-cardiothoracic patients. So of course, these patients are all considerably high risk. Many of them would have very compromised lung conditions in terms of a lot of atelectasis post-surgery, and their standard practice in this unit was to extubate onto 2 litres of oxygen. With EIT, they were able to see visually the difference in lung recruitment with 2 litres of oxygen and compare that to 50 litres of flow. So if we go to the next slide and run that video, this is a control. So this is what you would see if I put you guys on an EIT, we're all nice and healthy, and we can see the lung inflating and deflating as you're breathing in and breathing out. And that's a reflection of end expiratory volume there, and then you fully recruit your lungs. So that's a very good aerated lung with both sides working well. So good gas exchange, good ventilation. And that was the benchmark. That is what they certainly would like to see with their patients post-extubation, post-surgery. But the reality is quite a different story. If you go to the next video, this was actually one of the patients who started, and if we start the video, he started on 2 litres of oxygen. And you can see straight up how oxygen will not recruit alveoli. We kind of know that. You've got very reduced recruitment. A lot of one side is still pretty atelectic and pretty collapsed. They then transfer this guy from 2 litres onto 50 litres of air, and you instantly see this recruitment. So that is how high flow works with regard to maintaining pressure. And there wasn't a lot of pressure in this. They measured 3 or 4 centimetres of water pressure, but it was enough to re-recruit those collapsed lungs. So that's quite a good visual with regard to high flow. Okay, let's keep moving. The evidence, look, if we go to the next slide, just very quickly, I don't really want to go through this. I just want to remind us that high flow has been around for 10 to 15 years. The research started in ICU. There is a wealth of research and support for the use of high flow and hypoxemic respiratory failure, overwhelming support for the use of high flow for early extubation success, and also for prevention of intubation, successful prevention of intubation in the ICU. So we've seen some really good, really robust research coming out of Europe in that. We've more recently seen some good stuff coming out of emergency where they compared high flow to standard oxygen therapy and the risk of escalation of care, and some really favourable results. So we see a lot of use of it in resus bays and emergency. Just recently, some good work's come out of the ward. This was done in New Zealand, where they found that they could successfully treat hypoxic respiratory failure in the ward, and that reduced their transfer into ICU, and they had good success with the high flows. And we're talking flows of anywhere between 30 and 60 litres a minute. And the other end of the spectrum in palliative care, there's about 3 or 4 studies finding a number of things. Comfort is good. We're not looking at escalation of care. We're looking at maintaining these patients. And when you compare it to NIV, the outcome is equivalent. So it really is a choice, and the patients will often choose high flow. So yes, it's pretty well established. I think we're seeing a lot more use of it as the research is coming through, and there's a lot of really good solid research coming out because it's been out for some years. Okay, let's hit the next poll, and this is what everybody's wanting to know, so let's see what you guys think. So nasal high flow in COVID-19.
So we just need to launch the poll.
That's
And
the
here
one.
it
So
is.
nasal high flow therapy is not recommended for the treatment of patients with COVID-19. put this that you. Here we go.
Okay, so once again, a large number of you, 61% said false, which is actually the correct answer. So I'll hand over to Anna to discuss why that's the case.
It's interesting, very interesting. So if we have a look at just a couple of studies, just to put a couple of quotes of a couple of studies up there first up, and this info is changing daily. There is just so much research coming out on COVID-19, and the discussion about whether to use or whether not to use nasal high flow is quite contentious. This study came from, if you click on it one more time, it'll tell you the authors at the bottom there. I think this is the Lee study. Lee's done a lot of work with dispersion and the identification of bioaerosols, and initially these research were very cautious about the use of nasal high flow, but they quickly found that it actually really does significantly improve that hypoxic patient who you want to avoid intubation. So in their most recent study, they feel that high flow nasal cannula is a recommendation. And what is quite interesting about that is they suggest the use of a surgical mask on the patient's face above the nasal cannula. And that is their practice. And this was has recently come out of China. And if you click again, this study came out just last week. And this came out from Temple Hospital in the States, and they have had huge numbers of COVID coming through. And this gentleman did a couple of things. He actually identified two different phenotypes of the COVID-19 patients. The one he mentions here, the L phenotype, is a very mild ARDS type disease process. And I say that because the L phenotype patient responded very, very well to nasal high flow. And when he looked at his numbers, these patients don't need the high pressures, the ARDS do. They're not so concerned about the low tidal volumes. Their lungs are in quite a different state than the other type, which I think is the H type from memory. And he was looking at, among other things, intubation rates. And he managed to reduce his intubation rates he saved 64.4% intubations when he utilized nasal high flow for the L phenotype COVID-19 patients. So yes, he feels that it was a recommendation. And look, they're coming out daily with regard to recommendations and use of it. But I think when we look at the guidelines, the first thing you need to remind yourself of are the facts. And that brings me to the next slide. If we go 2 slides through, and that'll discuss the droplets versus the airborne, I think we've got to remember droplets are greater than 5 microns. The thought process is COVID-19 is spread through droplet transmission. And this is telling us that you need to be reasonably close to somebody with COVID-19. Droplets are quite heavy. They don't travel for very far. They are denser than the airborne transmission. And this is the thought process behind contamination. And if you compare that to your airborne transmission, these particles are much smaller. They travel for longer. And as a result of that, they are far more contaminant risk, so to speak. And in terms of the risk of exposure with an airborne potential particle, you triple your risk. And the I think the examples of that are the measles and the varicella virus. So there still is also a lot of debate about COVID. Is it in fact airborne? I think right now the consensus is that it's droplet transmission, but we've still got perhaps quite a lot to learn. And one person who has done an awful lot of work on this is David Huey from Hong Kong, and that takes us to the final couple of slides. Huey's done some interesting work with dispersion, as his concern was real, certainly with regard to different oxygen therapy interfaces and their ability to disperse potential contamination. And he uses a patient simulator in all his studies. So he's able to simulate a healthy lung, a mildly unwell lung, and a severely acutely unwell lung in his patient simulator. And he uses smoke particles to visualize dispersion. And if you have a look at this picture here on the left-hand side, that color change is dispersion with just 5 liters of cold, dry oxygen via nasal cannula. And that dispersion distance is 100 centimeters. He compared that to the right-hand side, which is 60 liters of nasal high flow humidified therapy, and that is 17.4 centimeters. So despite what we think, when you deliver cold, dry oxygen, and this is either via cannula or Hudson masks, the dispersion is far greater than nasal high flow. And I took advantage of a fantastic table that Lee presented in her recent webinar, which is the next slide, and that kind of shows you the numbers. And if you just hit the button, it's going to bring up 4 different highlights. So high flow at 60 is 7.2 centimeters in a normal lung. In a mild lung, it decreases to 7.2. So when you're mildly unwell, dispersion decreases, and it decreases once again with a very severe lung injury. But at no time is any of that dispersion anywhere near what you see with your nasal cannula at 1, 3, and 5 litres a minute. So a bit of food for thought. And I think this is great work. Yes, it's on a patient simulator, but this is the reason why David Huey did such work, as he felt that we needed to be sure about the facts of dispersion. And in terms of guidelines as a result of all of this work, I think we'll just bring up the guidelines before we run out of time. This is pretty much what they say. These change weekly or possibly daily. Yes, high flow is a recommendation for COVID-19, certainly in ICU, but the prerequisite is when you do run nasal high flow, you must wear full PPE. And the reasoning behind that is because they've listed nasal high flow as an aerosol generating procedure, which brings us to the next slide. So this is what the guidelines are telling us. And I think what we need to do with regard to interpretation of this is to have a look at the potential risk for generating aerosols. Absolutely, totally understand that. And also the generation of bioaerosols. This is patient generated aerosols, and high flow itself is going to influence that. We know the Airvo delivers water vapor, but the flow perhaps is increasing the risk of bioaerosols. This is kind of where the guidelines are coming from. So that is where we currently are with regard to the ANZAC's guidelines for the treatment of the COVID-19 patients in ICU. And I'm just wondering if we have time for that video, Ken, or if you want to get into the Q&A, depending on what we've got.
How long does the video go for again?
It's about 3 minutes.
We're probably pretty close to time. Do you want to tell people where they could access that video?
Pretty sure that video is a YouTube video, to be honest with you. So you can certainly do a YouTube search for Airvo setup. And if not, it'll be on our website. I'm pretty sure there's a setup section. And look, we've got it available if you want to get hold of us or get hold of your local rep. That's easy.
Actually, quite a few people are wanting to see the video, so maybe we should do that.
Okay. All right, let's do it.
Before the Airvo 2 humidifier can be used on a patient, you must ensure that it has been cleaned and disinfected. Check that the clean storage cover is sealed and its label is completed when you collect an Airvo 2 humidifier from storage. Some hospitals leave the red disinfection tube in place instead of using the clean storage cover to indicate cleaning and disinfection has been carried out. Along with the Airvo 2 humidifier, you will need the following accessories: an Airvo tube and chamber kit, which contains an autofill water chamber, a chamber adapter, and heated breathing tube, a bag of sterile water, and a patient interface. A number of interfaces are available for use with the Airvo 2, including both an adult and junior nasal cannula, tracheostomy interface, and mask interface adapter. Please read the separate user instructions for the patient interface that are to be used, including all warnings. These accessories need to be replaced for every new patient. For prolonged treatment, replace the tube and chamber kit and adult interface every 14 days. and for junior interfaces every 7 days. Open the packaging of the tube and chamber kit. Remove the blue port caps from the chamber by pulling the tear tab upwards, then remove the bracket holding the water supply tube. Fit the supplied adapter over the 2 vertical ports on the chamber and push on fully. Then clip the water supply tube into position. Fit the water chamber to the unit by pushing down the finger guard and sliding the chamber on, carefully aligning with the blue chamber port ends. Push the chamber on firmly until the finger guard clicks into place. Attach the sterile water bag to the hanging bracket at least 20 centimetres above the unit and push the bag spike into the fitting at the bottom of the bag. Open the vent cap on the side of the bag spike. The chamber will now automatically fill to the required level and maintain that level until the water bag is empty. To ensure continual humidification, always ensure that the water chamber and/or water bag are not allowed to run out of water. Check that water flows into the chamber and is maintained below the maximum water level line. If the water level rises above the maximum water level line, replace the chamber immediately. Next, connect the heated breathing tube. One end of the heated breathing tube has a blue plastic sleeve. Lift the sleeve and slide the connector onto the unit. Push the sleeve down to lock. Or, if using one of the newer style breathing tubes, simply push down while gripping the lower lip of the connector. Choose the appropriate interface. The Evo 2 is now ready for the patient.
Okay.
So we have some questions that have come up in the chat boxes here. So there's still a few people a bit confused about the COVID recommendations from ANZICS, which says that basically high flow nasal oxygen or high flow nasal therapy is still a risk of aerosol generating, despite the study showed that said as the patient's lungs get sicker, they are less likely to spread the droplets further. And I think that's got to do with how much tidal volume and pressure that they're producing because they're unwell. But because that study hasn't been replicated, perhaps in Australia, I think that's why the ANZICS recommendation is that it's a high flow or an aerosol generating procedure. And so we should, if we can, put a patient in a negative pressure room or a single room if possible. Now, I know a lot of people, there's a question here about rural areas. A lot of people don't have access to those in rural areas or smaller hospitals. So what would be your recommendation there, Anna?
Gosh, if you don't have negative pressure rooms, and I understand that, I think I saw one of those questions. In terms of the recommendations, I don't think the guidelines address that, but at the very least, you'd follow your standard PPE recommendations with high flow, and that's probably going to be the hospital's decision whether they utilise high flow or they don't in the absence of a negative pressure room. Because you're right, the guidelines have clearly stated that high flow is listed as an aerosol generating device, so you need to treat it as such. And I think you're also right with regard to the work. It's just one study and the guidelines are changing daily and they're madly trying to keep up with that. So possibly see what your guidelines for your hospital state rather than us have any recommendation on that. And if it is not to use it for those patients without negative pressure, then that's what you need to follow.
Yep, good. And someone's asked, why is the pediatric setting on the Airvo not able to be set at 37 degrees? Now, we are going to be covering pediatric patients in the next webinar on the 21st of July. So maybe give a brief answer to that now, and then we can...
Look, it's a combination of things. It's one of it's engineering, and with regard to the flows, we did use, upon introduction of high flow with children, they were very low, and our unit with very low flows struggles to reach the 37 degrees consistently. But now what we're seeing is, certainly with PEDS, we're using much bigger flows. So we're looking at perhaps changing the guidelines for that, but we need to validate the unit for 37. So there's a couple of reasons for that. We also know the kids are very comfortable at 34 degrees, and it's probably a combination of the limitations of what the Evo unit is able to achieve at the moment. So yeah, watch the space, but we can talk about that in the next session.
Okay, so someone's asking about the sizes for large and medium cannula sizes for the nasal prongs.
Oh, what they are?
Yeah.
Look, I couldn't tell you. Oh, you mean the actual diameters?
Yes, I think that's what they're
Couldn't
asking.
tell you the actual diameters. I can tell you though that overwhelmingly we use we see a most use of small and medium, and rather perhaps than getting fixated about the size, the whole aim of this therapy is to be comfortable. So whatever cannula you do choose, make sure that it fits loosely in the nares, so you have at least half the diameter of the nares showing. But look, we can absolutely, I can find the diameter out for you of the actual cannula, but I haven't got it on hand.
Okay. Now, a few people were sort of asking about if you have a ward patient, what's the flow rate? Well, that's dependent upon the patient, their underlying pathophysiology, and the need for alveolar recruitment to improve their oxygenation. And on top of that is, I always look at is flow is independent of the FiO2. So
yes. Look, that's a good question. We get it a lot, and I think the very first and foremost is what do your guidelines allow you to deliver, and that will be your possibly your limitation in some respects. But what we also are seeing is that some wards are now starting to be a little bit more free with their flow, and when you understand the concept of flow, the 30-litre starting point should be your baseline. That should really be where you start your flow, and there's really no concern of going up to 50 and 60 litres on the ward, but as I mentioned, that is going to be driven by the guidelines in your unit. And you're right, this is air. This is air being driven into a leaky system, and you think, well, what could possibly go wrong? I know that's a loose comment, but we're not talking about oxygen here. We're talking about 21%, and this is flow support, and they often do very, very well when you do provide just that little bit more. But it's a matter of the guidelines keeping up with the research that we now know is telling us that it's a real benefit.
I know that some hospitals have policies that in a general ward area, they can't have more than 40 litres per minute or 40% oxygen. And I think the reason for that is that if the patient requires more than that, they're probably deteriorating and need more advanced assessment and management.
That's very true. If you've got someone on, and you're right, someone on 50 litres at 45, 50%, that's a lot of oxygen and a lot of flow. So yes, they are very unwell, and they're probably getting support not dissimilar to non-invasive ventilation. So you're not just talking about nasal cannula, low flows of oxygen therapy here. So that's true. So yeah, that's, I think, another reason why the guidelines are in place, which is a good thing, because you don't want to end up in a place where you've maxed out on flow and oxygen and your patient literally falls apart in front of you. So the guidelines are there so that you have time to reassess and perhaps make that met call, etc.
And there's a few people that have been a bit confused about water vapor and the size of the molecule versus aerosol and droplets. And one of the slides did show that quite clearly, that water vapor was 0.001 micrometers, whereas a water droplet was 1 to 40. So much, much bigger and able to contain more of the virus load. So
look, it is an interesting discussion, and we don't want to, it's kind of the science of it. We don't want to complicate things, but I think, yes, water vapor is very, very small. It's an individual water molecule, 0.0001. And when you compare that to a droplet, as the definitions tell us, is greater than 5 microns. And that's kind of akin to your nebulizers. If you run a nebulizer, it's visual, you can see it. That's kind of like a droplet, and that's how we are transferring COVID. In between, you get airborne transmission, and airborne is, to be precise, is the nuclei of a droplet. So it's less than a droplet, it's smaller than a droplet, because it's just the internal parts of a droplet. So it gets a little bit involved, and some people have certainly studied it, but I just think you want to keep it simple and trying to put it into perspective with what you guys are running in your unit.
Now, there's a few people asking about the effect of, high flow on PEEP, which we talked about with CPAP and DPAP, and whether or not if a patient has an open mouth, if that decreases the amount of positive pressure in the alveolar airspace.
Look, yes, you'd think to yourself, gosh, a mouth open presents a big leak. So you're not going to get the pressure you will get if your mouth is closed. It's not a pressure device though. So if they persistently want to open their mouth, they're absolutely welcome to open their mouth. They're going to get the oxygen if you're titrating oxygen in, but they're not going to get the same degree of pressure as if they had their mouth closed. So that's the difference. It's a slight difference, but the pressures overall are quite conservative anyway. One study, as an example, delivered 100 litres into the upper airway, and the maximum pressure was between 9 and 10 centimetres of water pressure. So way less than your CPAP systems.
Yep. And then there's a few questions about weaning and how to go about it. And I generally approach this by saying, well, if the patient's on oxygen, we need to reduce the oxygen therapy for them to get them bound to room air potentially, and then reduce the flows. What do you think about that, Anna?
Yeah, it's interesting. There's two schools of thought here. My thought would be exactly that. Physiologically, we do very well on air. We breathe well on air. So let's bring them back to normal physiology. So my thought would be wean the oxygen down to 21% and then wean the flow. The other school of thought is, well, let's bring it down to 30 and 30. So wean it down to 30 litres and 30%. And when I looked at that concept, how I understand it is the reason why they wean them down to that level is because often they will put that patient on 2 litres of dry oxygen, which is very close to 30%. And that's where I kind of scratch my head, and I don't really understand why you would do that, but that often can be the case. And I think it's just a matter of confidence and understanding in what the flow therapy can do, really. But yes, my thought would be bring it down to 21%.
Good.
And then the flow.
There's a few people saying it's 15 litres high flow because some of the recommendations they've had in their hospitals that if it is a COVID suspected patient, they run them at 15 litres rather than the higher flow to limit aerosolization. So 15 litres is still high flow, but it's not as high as 40 or 50 litres.
No, it's interesting. Very interesting. They're kind of playing with definitions here. I think there is no definition of high flow. That's just been bandied around because high flow used to be anything above 6 or 8, anything above a Hudson mask. But when you look at 15 litres, that's probably half of a normal physiological peak inspiratory flow. So if they want to run 15 litres to get around the high flow thing, then I totally understand that. But yeah, it's quite a low flow. I wouldn't call that high flow.
Yep. Okay. Well, we really have reached our time limit here. So I would like to thank all of the attendees for their participation and interaction. Sorry we didn't get to all of your questions, but hopefully we answered more of the general ones. I'd like to particularly thank Anna for her presentation and Fisher and Paykel for sponsoring this series of webinars. And we have the next one on Tuesday, the 21st of July for pediatric applications, and then Thursday, 27th of August for Paku to the ward continuum of care. And I'd also like to thank Greg and Abby in the background for the tech support. A lot of people were having some problems and swapped over to the YouTube section, which seemed to fix that. At one stage, I think we had 941 participants, so that's a great number. So thank you very much, and Anna, look forward to seeing you at the next webinar on the 21st of July, and this one will be available as a recording, probably if not this week, but early next week, and you'll be able to access that through your Medcast learning portal. So thank you very much.
Thanks, Ken.
Thank you very much,
thank
Anna.
you all. Take care. Thank you.